Screening test for colorectal. So, if you have colleagues in your practice, educate them. No, sorry, it doesn't work. This is not a way around it. What we have to do is figure out ways to get patients to return those kits. My second presentation will go into some detail about ways to do that. It's also important to recognize for you all in the FQHC environment that the UDS measure does not count the digital rectal exam. It specifically says that an in-office obtained stool specimen does not meet the measurement standard. So if you're doing DRE to try to boost your UDS numbers, not going to work. They don't accept it. Now, there is, however, an approach for doing in-office testing that is evidence-based. Our recommendation is that stool testing be done as recommended by the manufacturer, which is how they got it through the FDA to get approved. So, I was given to talk about this and not doing the digital rectal exam. Oh, you all are cheating and reading here. Already read poop on demand. That's the label POD at the top, so it doesn't just grab your attention. I was given this talk in Florida 2 years ago, stressing the importance of not doing the digital rectal exam. And a medical director from the health center said, well, yeah, hold on. You can do it in the office. You can do it like we do. They ask the patient at the time that they're in the practice, okay, they tell them about colorectal screening, educate them about why it's important, they give them the stool kit, and then they ask, can you go right now? A surprisingly large number of patients can go right here. They set aside a bathroom, and it's their poop on demand bathroom, and they give them the kit and have them collect the specimen right there. So they're collecting it as it's recommended by the manufacturer. They're not doing a digital rectal exam. They're getting a complete specimen, but they're not sending the patient home with the kit and hoping that they'll return. And they boosted their return rate from somewhere around 33% or so to 50% in less than a year by adding in this poop in demand. And that wasn't the only thing they did. They assigned nurses or medical assistants to really do some intensive education with patients, and then they also do follow-up phone calls for those patients who can't go out there in the practice and return. But they boosted their rate very significantly. If you're going to do it, it is imperative that you're using one of the tests that is demonstrated to be effective with just collecting a single sample, because you're only going to get one bowel movement while they're in the practice. I guess you could have them come back the next day and prove again. That seems a lot to ask. So you have to be using one of those single sample kits that has shown high sensitivity. But I was in Florida again a couple of months ago, and a number of the other health centers that were at that presentation and heard that mention, or who had heard about it subsequently, have now adopted it. So it's becoming kind of a standard in Florida health centers to offer people on demand for their patients. Now, I mentioned that all fits are not created equal. And the question about the iFOB, the IFOBT, triggered that thought in particular. There are a lot of different fits in the marketplace. As a matter of fact, I was at a presentation last week, and some investigators went through the entire FDA database, and to the best of their knowledge, were able to ascertain 56 different fits for iFOBs that have been cleared by the FDA to be marketed for colorectal screening in the U.S. Now, what is important is actually they're not cleared by the FDA to be marketed for colorectal screening. They're cleared by the FDA as tools that can find blood. Because all you have to do at present to get FDA approval is show that you can find blood. And in many instances, they just take 5 milliliters of blood and stir it up in a stool specimen and compare the results of their test with something that's already on the market, which in many instances is just Hemocolt 2. So if they're as good as Hemocolt 2, which is no longer recommended for colorectal screening, then they can get into the marketplace. So that's how most of those 50-some tests have gotten into the market. They're as good as Hemocolt 2. Most of them have done no work to demonstrate their ability to find cancer or find polyps. The vast majority have not done it. Of those 56, there were 23 that are still in the U.S. marketplace. Of those 23, at best, a quarter of them have actually looked at their ability and published data showing their ability to find cancer or polyps, which is what we're really looking for. Now, we brought this issue to the FDA a couple of years ago, and they actually, shockingly, they listened. They said, oh, well, that's an important issue. So they are in the process now of revising their guidance to get these tests into the marketplace. No copay or no deductible for your patients for any of those kinds of tests. And for colorectal screening, it means any test that is recommended by the task force, which right now would be FIT or WIAC test or flexible sigmoidoscopy or colonoscopy. So your patients with Medicare should be able to get the colonoscopy if they choose that as their initial screening test with no out-of-pocket cost in most cases. If, however, a patient chooses Cologuard as their initial screening test, or if they choose a $20 FIT test as their initial screening test, well, now they've used up that screening benefit. So if that Cologuard or that FIT test is positive and they get referred for colonoscopy, now they're subject to cost sharing. They may end up having to pay $200 or $300 copay for the colonoscopy. So your patient should understand the potential financial implications of choosing one of these other tests before they launch anything. I just got the 10-minute mark, but I think this is my last slide, actually. There are a couple of other screening tests that you may or may not have heard anything about yet. And these tests are not included in the guidelines of any organizations, but both have some limited clearance for marketing in the U.S. There is a blood test that was just within the last couple of months received FDA approval, and it's a test that looks for methylated acetylmethylmonate. So you draw blood from someone and look for a DNA change that's associated with colon cancer and to a much lesser degree polyps. And I think the study that got them approval, their sensitivity for colorectal cancer was somewhere in the ballpark of 60%. So they're going to miss a significant number of cancers. But their acceptability among patients was very high. And that, frankly, to me was not surprising. The fact that as opposed to telling a patient you got to go for colonoscopy and go through the prep and somebody put that tube up the butt, or telling patients go home, collect some stool specimens, patients are told, oh, stick out your arm and draw some blood. And they're used to doing that anyway. So they're very willing to have their blood drawn. But this test, because of, I think in part at least, its relatively low sensitivity to cancer, the FDA approved it only for patients who have repeatedly failed to follow up on other screening, on other kinds of screening. So patients who have repeatedly failed to follow up for colonoscopy, repeatedly failed to collect stool specimens. How they plan to enforce that, I have no idea. I don't know how the FDA, I don't know what kind of documentation is required to demonstrate that repeated non-adherence. But this test is approved for use in that limited number of patients. The other test is what's called capsule endoscopy. You may have heard of it, PillCam. It's actually a pill that you swallow. The initial version of the PillCam was designed to look mainly at the upper GI tract and the small bowel in particular, where you couldn't get an endoscope. But they've done some subsequent testing looking at swallowing that pill or a different kind of capsule, having it go all the way through, and then tracking the colon, tracking within the colon. They received approval close to 2 years ago now for failed colonoscopy. So if an endoscopist is, for whatever reason, not able to get all the way through the colon, then a PillCam is an option. So patients can use that as another approach to complete the colonoscopy. Somebody says, no. Okay. So anyway, these tests, again, neither of these are included in the guidelines of any organizations, ACS, the Human Services Task Force, or any of those. But because you may have heard, or your patients may ask you, I just thought it was important to mention. Okay, that's it for the science portion of the talk. And do I have a couple of minutes for questions?
Yep.
Okay. So, questions? Yes, ma'am.
With the Cologuard, do you still have to do FIT tests or some other kind of screening between the 3 years?
No, the question is, with Cologuard, do you do other screening in between? And the answer is no. It's recommended by the manufacturer as an every 3-year test. The evidence for that 3-year interval isn't really clear, and the FDA, as part of their approval process, has asked them to collect data. It may be that every three years is not often enough, but it may be that every 3 years is more often. Maybe it should be an every 5-year test. So we don't know. So the company is continuing to collect data and try to look at what an appropriate screening interval is. So 3 years is what's currently recommended, and doing tests in between is not currently recommended.
Is the last thing that you talked about, is that the same thing as a virtual colonoscopy, or is there something different about the virtual?
Virtual colonoscopy is entirely different, and I should have added a slide on virtual colonoscopy. Virtual colonoscopy, the technical, the formal name is actually CT colonography, and it is using very, very thin slice CT scan images that are, the patient goes through with is a typical CT scan, only they use a special thin slice scanner, multi-detection scanner. And then they compile these images in such a way that when the radiologist sits down and looks at those scans, they look at it, in the normal fashion that they would a CT, but then they also do what's called a fly-through version. And if you've never seen it, it's kind of cool. Go online and take a look. It's almost like playing a video game, but they are moving through, the scanner reconstitutes these in a way so it looks like the pictures or like the images you see doing a typical optical colonoscopy. So they move through the colon and they can find polyps and determine exactly where those polyps are. They can find cancers. There have been a number of studies that have looked at CT colonography, and it's been included in the ACS guidelines since 2008. Because the largest and the best study, they compared it with, they did CT colonography, and then on those same patients, they did, someone came in and did a typical optical colonoscopy, and they found that CT colonography found about 90% of cancers in a fairly large proportion, more than half of the large polyps that were likely to transform into cancer if left alone. For a variety of reasons, the Preventive Services Task Force has been reluctant to give an A or B recommendation to CT colonography, and again, in its draft guidance, it put CT colonography in the same sort of off category that they use for stool DNA, that is appropriate for some patients, but not an A or B recommendation. Again, they've not finalized that guidance, and maybe they'll shift their position. But it's been included in ACS guidelines since 2008, and evidence has been accumulating that it is a very effective approach to colorectal cancer screening, at least from our perspective. Okay, 2 more questions. One here and then there.
Do you think the American Cancer Society and other pressures are going to be put on to get all insurances to cover prevention? Or the screenings? I know Blue Cross, for colonoscopy screenings, like Blue Cross and Blue Shield won't cover prevention screenings. Most of them.
Well, if they are an ACA compliant plan, which again accounts for more than 90% of plans, they're supposed to cover with no copay or deductible. If that sounds like an issue for our ACS CAN folks. I don't know that we have anyone from ACS. We do have ACS CAN here. Is it accurate that Blue Cross Blue Shield does not cover screening colonoscopy in the state?
Oh, goodness. It depends on whether or not it's a grandfathered plan.
Right.
So if it's on the marketplace, those are covered. And so we've been telling people that you need to call member services from their insurance company and find out.
Ours doesn't. Sometimes.
Yeah. Well, there are potential legislative and policy fixes, and I don't know, is Blue Cross Blue Shield here in the room? I'd be happy to talk to you all. There are very good reasons for insurance plans, particularly a plan that's dominant like Blue Cross Blue Shield is in this state, to provide coverage, because covering one case of advanced cancer is going to cost them an awful lot of money. And the cost benefit of screening, preventing cancer, or finding cancer early likely offsets the cost of, or would be offset by the cost of treating late stage disease. So there are a lot of good reasons. I don't know where ACS stands with regard to, trying to create a legislative solution. I know in some states, they actually pass laws that require, and this was pre-ACA, that tests that are included in the Preventive Services Task Force or ACS guidelines have to be covered by the insurer. So if they're not covering screening exams, they're way behind the curve with regard to the vast majority.
I think that might be in certain areas, but in our area, our service area in Beulah Hazen, we have all Blue Cross Blue Shield plans are pretty much covering screening colonoscopy. So I think it might be.
I think where it comes in is co-pays and deductibles.
Right.
Yeah.
Right. Now that's where the ACA compliance piece becomes important. If you are a grandfathered plan, you don't have to follow that, no copay, no deductible. But if you turn a $3,000 colonoscopy into a $300 colonoscopy because you just have to pay the copay, that's still challenging for many patients in low-income environments, but it is at least something. And many hospitals or endoscopy centers are willing to work out payment plans. But we are in the process actually of trying to address that issue because for Medicare in particular, while if an individual has a colonoscopy and it's labeled as a screening colonoscopy, and then some abnormality is found. It was a glitch in the ACA, so that patients would go to sleep believing they were having a screening exam. Then a polyp was found during that colonoscopy, and suddenly in midstream it was switched to a diagnostic exam, so now they got a copay and they didn't expect it. That has actually been fixed for ACA compliant commercial plans. If the patient goes in for a screening exam, regardless of what's found, it should still be coded as a screening exam. There should be no copay. But with Medicare, that glitch is not fixed. So we're working to fix that glitch so that Medicare patients don't experience that unexpected copay. The other issue is what I mentioned earlier, that is if someone chooses to have an FIT test or a Cologuard, but in particular an FIT as their initial screen, no copay, and then that FIT is positive, then when it's time for the colonoscopy, now it's considered a diagnostic exam, and they end up having to pay that copay. We are working with CMS, and actually there's a legislation, I believe we have a handout back there about the legislation that's being proposed to try to resolve that issue, because from our perspective, a positive FIT is only half the screening exam. Doing the follow-up colonoscopy that is required is simply completing the screening. It's not diagnostic, because most of those patients, frankly, are not going to have cancer anyway. But you don't know until you finish the screening test. So we are trying to help the government understand that this is a continuation of the screening process, and therefore copays or deductibles should not be applied. So that's underway. All right, I think that lunch is already out there, and
we have one question from the South Dakota.
Oh, I'm sorry, can I answer South Dakota?
Yes. Flat, whenever you're ready.
Can't hear you.
You need to unmute.
Yes, yes, you can.
Colonoscopy, I start to now annually.
I'm sorry.
We are having a little bit of trouble hearing. Can the person asking the question move closer to the microphone, please?
Can't get much closer because it's in my mouth.
Larry, can you hear me?
Yeah.
Yes.
Okay, so his question was, if you've had a colonoscopy and your 10 years has completed, so now you're due for a screening again, can you start up doing an annual fit?
Yes, after that 10-year window, the patient is free to choose whatever screening exam they feel is best for them. So if they want to go with FIT, if they want to go with Cologuard, anything that is on the approved list is reasonable after that 10 years. Most people just choose to go ahead and have another colonoscopy because they don't want to be bothered like me every year or every 2 or 3 years. But it's perfectly reasonable to shift if they wish. What we see much more often is people start off doing fit every year, and then after a year or 2 or 3, like, I'm tired of doing this. Do I have another option? And they end up then shifting to colonoscopy. Okay.
Thank you, Dr. Brooks. So, this sounds kind of loud. We are going to take a quick break. You can get up, stretch, use the bathrooms, your plates. Lunch is right out here. And come back by about 12:05 because we will have a panel discussion during lunch.